Afternoon, dear colleagues. My name is Olga Tishkova. I'm from Russia. I represent Astrakhan Medical University. Dear colleagues, I would like to thank the organizers for the opportunity to present your work and to share it with this distinguished scientific community. Today we will talk about the role in the transcription factor NRF2 and apoptosis proteins in early pregnancy loss and their potential as novel diagnostic biomarkers. Early pregnancy loss remains a major challenge in reproductive medicine. Up to 50% of cases remain unexplained. Current clinical tools confirm pregnancy loss but don't allow early prediction. Therefore, molecular mechanisms such as oxidative stress and apoptosis are of particular interest. Early placental development is highly sensitive to oxidative stress. During normal pregnancy, controlled levels of reactive oxygen species are required for trophoblast differentiation and invasion. However, excessive reactive oxygen species leads to cellular damage, mitochondrial dysfunction, and activation of apoptosis. Apoptosis is a key physiological process in placental development, but its dysregulation contributes to pregnancy loss. Two major apoptotic pathways are involved. Extrinsic pathway, activated white death receptors such as FAS. Interaction between FAS and FAS-L triggers caspase cascade, leads to programmed cell death of trophoblast. Intrinsic pathway, triggered by intracellular stress, leads to mitochondrial dysfunction, results in release of pro-apoptotic factors. A central regulator of oxidative stress response is the transcription factor NRF2. Under physiological conditions, NRF2 maintains redox homeostasis by activating antioxidant genes. Thus, a key model of early pregnancy losses can be presented through the activation of oxidative stress and apoptosis. Dear colleagues, look at what has already been studied. But there are still unresolved issues. Research objective. The aim of our study was to evaluate NRF2-related mechanism and apoptosis proteins FAS, FAS-L, and AIF as potential biomarkers of early pregnancy loss. Study object: serum, aspiration fluid from the uterine cavity, chorion tissues. Method: enzyme-linked immunosorbent assay for assay, transcript factor NRF2, apoptosis proteins FAS, FAS-L, and AIF. The study included three groups: miscarriage, spontaneous miscarriage, and control group elective abortion. As a result of the study, a gradient decrease in the level of NRF2 from the control group to spontaneous miscarriage and non-developing pregnancy was found. Increased markers of FAS, FAS-L, and AIF apoptosis at early pregnancy loss were observed in serum. We observed a significant increase in AIF, FAS, FAS-L. This indicates systemic activation of apoptosis. In aspiration fluid, we found increased AIF, decreased FAS and FAS-L. This likely reflects tissue destruction and loss of cellular regulatory mechanism. Korean tissue. The most pronounced changes were observed in Korean. AIF increased up to 8-fold. FAS increased up to 8-fold. FAS-L remained relatively stable. This suggests that the primary damage occurs at the level of trophoblast. We propose the following pathogenetic model. NRF2 deficiency leads to oxidative stress, which activated FAS-L signaling, causes mitochondrial dysfunction, AIF release, and trophoblast apoptosis. No single biomarker is sufficient. May serve as a promising diagnostic tool for early prediction of pregnancy loss. The limitations are presented on the slide. Conclusion. Early pregnancy loss is associated oxidative stress and dysregulated apoptosis. NRF2 plays a protective role while FAS, FAS-L, and AIF reflect different apoptotic pathways. Their combined assessment offers new opportunity for early prediction of pregnancy loss. Thank you for your attention.
I would like to speak today about endometrial cancer, evaluation of diagnosis and treatment strategies, focus on ESGO, ESTRO, ESB guidelines 2025. And let's go. That's just a second. I have a problem, setting problem here. I should work parallel. That's why I have to. Just a second. Okay. Okay, you can see now, right? Is everything fine?
Yes, everything is fine. You can proceed with the presentation.
Okay. Here we are seeing the first objective to understand the evolution from conventional clinical pathologic disclassification to molecularly informed care. The second is to apply to integrate language of figure 2023 and ESGO, ESTRO, ESP guideline. The third and fourth objectives, they are practical, and it's about how to select surgical staging and adjuvant systemic therapy. Emphasize that the talk, it's a structured clinical summary for daily tumor board. First, we have to understand why molecular classification became clinically necessary, then apply, then select and match, and that's we make an individual therapy. Let's talk about in endometrial cancer. Is one of the most common gynecological malignancies in developed countries, and incidence is increasing with obesity and population aging. 2025 guideline class is like 417 1,000 new cases and 97,000 deaths worldwide in 2020, and 24,000 new cases and like 30,000 deaths in Europe in 2022. It's really heterogeneously two tumors with the same stage and histological grade may have very different relapse patterns. Therefore, the modern goal is precision in both directions, de-escalate when biology is favorable and escalate when biology is aggressive. And the older classification, like we see here, pre-2013, was clinically too crude. We had just two types, type 1 and type 2. But after TCGA 2013, creating a molecular map of endometrial carcinoma, they are all ultramutated MSI, MMRD, deficiency or hypermutated, or copy number low in NSMP, or copy number high is like P53 mutation. And then came 2021. It's like came an ESGO risk model. Guideline already moved toward the molecular risk stratification on FIGO 2023, formally integrate molecular classification into staging, and 2025 the guideline ESGO update with, as I said, incorporated with FIGO 2023 and new evidence across the entire care pathway. The case synthesis and molecular biology has moved from to the lab into the tumor board. All we see here that for types, like I said, all mutated tumor are ultramutated and usually have an excellent prognosis, even when morphology looks high grade. MMR deficient tumors are important both for Lynch syndrome screening and for sensitivity to immune checkpoint inhibitors. NSMP, non-specific molecular profiles, is a heterogeneous and require careful interpretation with hormone status. And also there are other clinical parameters like LVSI, grade, stage, pediatric tumors. The point is that molecular group is not only prognostic, it's now treatment modifier. We see how to molecular workup, make every diagnosis actionable. This is a practical diagnostic algorithm, the 2025 guideline that complete molecular classification, including pol mutation, MMRI, intrinsic immunohistochemy with MLH1 promoter, methylamine listing when MLHI or MLH1 or PMS2 both is present. Is preferred option and should perform all partition when feasible. That's important. The operational point is timing. The result must be available early enough to influence risk assessment and adjuvant therapy. It should be ready for tumor board, and case without molecular classification is increasingly incomplete. FIGO 2023 is a major conceptual change. It includes the subtypes LVSI and molecular classification alongside anatomical spread. When molecular classification is available, the stage can be recorded with an M. Subscript, the practical tumor board point is that FIGO stage is no longer only a surgical anatomical label. It's a part of risk model that drives treatment. That's why pathology, molecular diagnostic, and imaging must be integrated before adjuvant therapy decided. This guideline is not just adjuvant therapy table. It covers diagnosis, management, follow-up, and patient education. It incorporates the review FIGO 2023 staging system with a large body of new evidence. It's also make the multidisciplinary nature very explicit. Pathology, surgery, radiotherapy, systemic therapy, radiology, and survivorship are linked. For the yes, here we saw all the parameters that we have to include. In modern endometrial cancer, diagnosis should be presented a complete decision package. For pathology, we need histology, grade, P53, MMR all, and often hormone status, and also LVSI and invasion parameters on final specimen. For imaging, MRI remains important for local staging, especially myometrial and cervical invasion. CT or PET-CT used selectively when there is a high risk or advanced disease suspicion. The final NDT output should be a VAC recommendation. Yes, they are yes. And if you are going to surgical treatment, become more precious for presumed stage 1 and 2 disease, standard surgery remains total hysterectomy with bilateral salpingo oophorectomy and lymph node staging. It's like it's sentinel staging, for example. Minimal invasive surgery is preferred when feasible, even high-risk patients. And omentectomy is recommended for clinical stage 1-2 serous carcinoma, carcinosarcoma, or undifferentiated carcinoma, but not for all histologies. In over stage 3 or 4 disease, stereodictive surgery should be considered only when complete macroscopic resection is feasible. Is like an ovarian cancer. The guideline especially discourage systematic lymphadenectomy in that stereodictive surgery. Suspicious node should be removed. Sentinel node mapping should be present as a staging tool, not just a surgical technique. It's a value that it provides nodal information with a lower morbidity than systematic lymphadenectomy. Nodal status affects risk groups, assessment, radiotherapy decisions, and sometimes systemic therapy. The results should be interrupted with pathology details, macrometastasis, micrometastasis, or isolated tumor cells are not equivalent. A failed mapping site requires a protocol-based response rather than being ignored. Yes, next slide. We have 5 groups. The risk stratification, it's a heart of ESGO, ESTRO, ESP guideline 2025. This slide is a core of the talk. This 2025 guideline organized adjuvant treatment by integrated risk group. Low risk patients should be receive adjuvant should not receive in adjuvant therapy. Intermediate risk patients can be considered for vaginal brachytherapy, but no adjuvant treatment is also option in selected cases. For example, POL mutated. High intermediate risk prioritize pelvic control, usually like external radiation, EBRT with vaginal brachytherapy. High risk disease generally requires combined local and systemic treatment. In the uncertain risk category also we have is important because the evidence is not it's not. We have to look in other parameters if you don't know what should be the patient like adjuvant therapy. Next slide. Okay, we have here. That's why the normal molecular red flags that change the plan. We have POL mutation patients. They have excellent prognosis. We have to avoid an over-treatment. We have also P-derived abnormal patients that we have to escalation. We have patient MMRD deficiency that we have look for the limb syndrome, and we have also we have to consider that we have immune therapy option. And we have also NSMP group, non-specific molecular profile. They are like 90% of this group. They are like hormone positives, but there is a like 10% of this group. It's like they are hormone negative, and they are also like P-derived abnormal. They have also bad prognosis. That's why we have to consider all of these groups like NSMP. They are not equal for the prognosis. Okay, and next slide. Okay, then came a young patient fertility and ovary presentation. We can make it 2, but in selected patients like G1 endometrial, endometrial type, no muscle invasion, no extrauterine disease. And we can make a treatment route like progesterone-based therapy or LNG intrauterine device. Then we can make monitoring like biopsy every 3 to 6 months. Then we can then in that time can the patient maybe can be pregnant. If we have always the disease, then we have to talk with the patients, and we should decide what's the alternatives, or it's like you making a surgery. Okay, I have 2 cases. It's first case is patient A. It's like 62 years, endometrial carcinoma, G3, stage 1A. It's like less than 50% millimeter invasion, LVSI negative, PN null on POL pathogenic mutation. And it's if the POL mutation if POL mutation is like it's better, has a better prognosis, and it's we can de-escalate in this group. Its risk group shifts towards the de-escalation. She has a G drive, but she has a POL mutation. That's why escalation we should make, and it's like low risk situation. Tumor board recommendation should be low risk situation. That's why they escalated rational and discuss omission of the adjuvant therapy if guideline criteria are met. The second case, patient B, 68 years, endometrial carcinoma, G2, sentinel node negative, and P-derived is like abnormal pattern. In this case, integrated interpretation, P-derived 53. Sorry, I talk like German, but I have to switch. I didn't realize. P53 abnormal. It's like aggressive biology. LVSI adds recurrence risks and consider like high risk. That's why we have to escalate in therapy. Tumor board recommendation concept. Do not rely on uterine confinement alone. Evaluate combined local systemic adjuvant options according to the final risk group. In this case, it's like high grade because of LVSI positive, and also stage 1B, and P53 is abnormal pattern. Follow-up on survivorships it's important too. Patients should be informed about signs of symptoms of recurrence and long-term side effects of therapy. The guideline explicitly states that the primary objectives of follow-up included physiological support and detection of health problems, but there is no evidence that follow-up improve overall survival. Therefore, follow-up should be personalized according to molecular and clinical risk, treatment received, side effects, and comorbidities and patients' needs. Implementation of tumor board checklist. A good MDT role should be not only is the therapy, it should be listed it that has justified it. The checklist for the tumor board and the adverse stage, histology, LVSI, nodal status, molecular subtype, ER status, where relevant and patient-specific context. The outputs should include the risk group, treatment recommendation, rationale alternatives, and patient discussion points. This is especially important when recommendation are de-escalate or when the evidence is uncertain. Take-home message: endometrial cancer is now molecularly informed. ESGO 2023 integrates histotype, LVSI, and molecular subtype into staging. ESGO ESTRO ESP 2025 translates this into risk-adapted treatment intensity. All mutated is the strongest de-escalation signal. P53 abnormal is an escalation signal. MMRD matters for low synchronous immune checkpoint strategies. There are also some open questions. Therefore, can all palliative tumor safely avoid adjuvant therapy? Or what's the true clinical significance is related to tumor cells? Mutated tumor, it's the strongest de-escalation signal is endometrial cancer. Multiple retrospective and translation analysis show excellent outcomes, even in tumors with otherwise high-risk morphology. However, an important unanswered question is whenever all mutated tumors can safely omit adjuvant therapy. Prospective long-term data are still limited in some subgroups, especially in advantage states or mixed histologies. Therefore, despite strong evidence supporting de-escalation, individualized MDT discussion remains important. For example, we have a patient with Pol mutation, but if she has a FIGO stage 3 stage or FIGO 3C, we don't know if we de-escalated therapy. What is the true clinical significance of isolated tumor cells? If you make a sentinel and we have isolated tumor cells in sentinel node, the challenge is that ETs, isolated tumor cells, do not necessarily behave biologically like true nodal metastasis. Their prognostic significance appears lower than micrometastatic or macrometastatic disease, but recurrence risk may still be slightly increased compared with completely nodal negative patients. Current guidelines therefore recommend integrating ETs into overall risk profile rather than interpreting it in isolation. That's why if you can decide the patient that need adjuvant therapy or no adjuvant therapy, in this case, we have to consider other parameters. And if you at the end of the day, if you don't know what should we do, we can escalate the therapy. How reproducible is substantial LVSI assessment between pathologies? This is a very relevant practical issue. It's local from it's like this distinguishing if local from substantial LVSI directly affects ESGO risk classification and therefore adjuvant therapy recommendation too. However, inter-observer variability between pathologies still exists. Standardized pathology reporting and increasing subspecialization in gynecology oncology may improve reproducibility in the future, but now it's like we have to consider it, but it's like hard to decide. Should universal molecular classification become mandatory worldwide? Scientifically, complete molecular classifications become the preferred modern standard because it improves prognostic precision and directly influences treatment intensity. However, global implementation remains challenging. Access to pole sequencing, molecular pathology intrastructure turnaround times and financial resources differ substantially between healthcare system. One of the future challenges will be making precision oncology broad, accessible, and not limited to certain centers. And also, can AI-supported decision system improve multidisciplinary tumor board safely? Artificial intelligence may become increasingly relevant in gynecology and oncology, especially for integrating large amounts of pathological, molecular, and imaging data. AI-supported system could potentially improve standardization and guideline adherence. However, several concerns remain unsolved, including transparency, validation, bias, accountability, and patient safety. Therefore, AI should currently be viewed as decision support tool rather than a replacement for multidisciplinary clinic expertise. They are my key references, and thank you for your attention.
Hello everyone, this is Dr. Nuri Ishrat Najmi from Bangladesh. I'll be talking on my article on knowledge and practice of caregivers for the management of their febrile children, Bangladesh perspective. So this is a clinical study on knowledge and practice perspectives from Bangladesh. Well, why this study matters? So, the parents' anxiety and dissatisfaction may sometimes lead to repeated consultations with different doctors and increased hospital admissions, thereby increasing the burden and cost to the healthcare setup. So, I tried to find out what's bothering the caregivers. So, the most common pediatric symptom, is the fever. So, fever accounts for over 30% of global pediatric healthcare visits. And pediatric fever is a common symptom that is mostly caused by self-limiting infections. However, fever in children is often inappropriately managed by the parents and driven by a lack of appropriate knowledge, and it leads to undue anxiety and frequent healthcare consultations, as I have told already. So fever phobia. This is a widespread parental anxiety leading to undue psychological concern and healthcare burden. Fever phobia remains extremely widespread, not in our country. Also, it's prevalent all over the country. And the scenario is almost the same everywhere. Inappropriate practices include measuring temperature by hand, providing inappropriate dose of antipyretics, cessation of breastfeeding in febrile children, making ice-cold water, sponging or baths, and rubbing the child's body with alcohol even vinegar or lemon. In addition to the over or underdosing of antibiotics, the substantial misuse of antibiotics to manage merely pediatric fever by overconcerned parents is frequently associated with antimicrobial resistance. This is a global issue for developing country. So evidence-based practices are often lacking due to knowledge gaps in home management. Mismanagement can lead to safety risks such as incorrect dosing or delayed professional care. So, I tried to find out what is the main concern of the caregivers. So this study aims to determine caregivers' knowledge and practices for managing their febrile children and to assess the factors influencing these practices. I involve not only mother or father, nowadays, many of the mothers are working women. So I tried to cover the caregiver, like even maid, even the relatives who takes care of the children whenever there is onset of any fever in home. So my methodology was was actually a comprehensive analysis of 350 caregivers in 2 military hospitals. So around 30 to 40 pediatric patients report to our OPD in these military hospitals during working hour. So a convenient sample of 350 mothers, fathers, or attendants other than parents who were actively playing the role of primary caregiver of the respected child and who attended OPD along with the child were included in this study. And the data collection was by accomplishing after a pilot study on 20 mothers. So after that, I tried to make a questionnaire, and it actually covered 4 parts, including demographic variables and also the difficulties encountered by parents or caregivers while managing febrile children. Thirdly, I tried to find out what is the level of knowledge and then the practice of the caregivers while managing a febrile children in their home. So there was 96% respondents were mothers with a mean age of 25.9 years. So you can see most of them were younger age group, and educationally there are 74% of the participants were at the undergraduate level, primarily working as homemakers. And 87% of the respondents were from urban areas, and all of them sought care at outpatient department of our military hospitals. And I found in the results section that there are key discrepancies, like 60% of caregivers use their hands to feel temperature rather than using a thermometer, which is the standard measurement procedure. And there were controversy regarding definitions. So favored definitions among parents varied widely, ranging from 98 to 102 degrees Fahrenheit. Most of them failed to define when you call it as a fever or what is the measurement of the temperature when you say it as fever. So there was also a majority of the participants reveal their concern about febrile convulsion. So high level of concern regarding febrile convulsion, despite most fevers, are self-limiting. So it's also a concerning factor. So, this is the table I found in my study. You can see 95% of the caregivers or the attendants had no definite knowledge about the fever definition, and most of them had poor knowledge about paracetamol dose, frequency, and overall management of the febrile children. And there was a paracetamol dilemma. This is the most another concerning factor. 86% of the caregivers lacked dosing knowledge, and misunderstanding of the safe intervals between doses were also another concerning factor for us, for the clinicians. We know that paracetamol might cause sometimes liver failure. So giving it too frequently is not a good thing. But instead, sometimes they know that it might be harmful for the children giving too frequent paracetamol. Still, with a high concern, they give it too frequently. So it is also observed in my study. And 89% of the preferred oral, 89% of the caregivers preferred the oral route of paracetamol for administration during fever of the children, and 90% still preferred consulting a doctor before giving any medication, and whenever there is a first episode of fever they found. You can see here it is the demographic variables of the attendants who participated in my study as the attendants of the children. And initial management practices, you can see here the temperature management. While they measured the temperature, 60% of them use hand touch method, but using digital thermometer is the recommended technique. And regarding fluid intake, inadequate fluid provision reported by almost all of them, but increased oral rehydration and breastfeeding, it is recommended. But most of them didn't know about this regular practice of increased hydration during fever. Physical sponging, it's 14% relied on traditional method like ice cooling method, and sometimes like using some leaves even. But tepid water sponging with lukewarm water, the knowledge is deficient in most of the parents. And the initial step, 35% gave antipyretics immediately, and monitoring and whereas monitoring and comforting, if it is below 38.5% is the recommended schedule. But most of them just give antipyretics immediately whenever they find there is fever. And you can see here another table of mine, caregivers practice regarding management. So you can see here again that 86% of them use their hand, and 95% use armpit whenever they use thermometer for measuring temperature. And preferred route was oral, and sponging or cold compress was evident in 46% cases, and increased fluid intake, it was present only in 15%. So only 15% of caregivers knew that increased fluid intake is required during fever. And the traditional method, another traditional method is homeopathic medicines. So other than normal paracetamol, they tried homeopathic medicines, or also traditional medicines, in some leaves, some herbal medicines, which might be harmful for liver or health. So these were the other traditional methods, which is not scientific even. You can see here the difficulties encountered by the caregivers. So difficulties encountered, you can see 34% of them, they measured the temperature of the child, only 34%. And administering medicine to the child, it was by 49% of the caregivers. And 55% of them had difficulty in deciding the correct dose. So almost half of the caregivers were not aware of the correct dose of the paracetamol. And there are some difficulties again regarding choosing the frequency of antibiotics. Some of them give it too frequently. Whenever there is fever, it is not subsiding, they even gave it 1 to 2 hourly, which is a really concerning factor. And there is almost 60% of them had concern about febrile convulsion, and other concerns like brain damage, dehydration, coma, and death might be due to fever. So 14% of them thought like that. And another concerning factor for us, antibiotic misuse, it was a major concern. 51% of them preferred antibiotic in their home before visiting a doctor. So it is, I think it's crucial to remember for us, for the clinicians. And most of them prefer cefixime as the first choice of antibiotic. Secondly, I found azithromycin was there in the choice list. So predictors of knowledge and practice, in my result, I saw maternal education and family income were significantly associated with better knowledge of fever thresholds. And mothers with previous history of children, recurrent illness, or multiple children showed slightly improved practice levels, or even the knowledge were slightly better than others. And the role of maternal occupation was also important. You can see employed mothers and those with professional backgrounds, some were doctors, some were nurses. So we were more likely to use thermometers. So who were educated more, or more with health professionals or having some medical professional background, they more likely use thermometers and could understand paracetamol dosing correctly compared to younger and less educated homemakers. So working mothers also had a better idea than the homemakers' mothers. So I had some limitation of my study. This was a single centered study, and only 2 small center of military hospitals were covered. And the restricted it was restricted to those who agreed to participate only, which might have excluded parents of children having more vision. Again, our study represented a large population of educated and solvent parents, with an easy accessibility of healthcare setup, which may not be the reality in the whole community of our country. So therefore, opportunities to perform further studies in different localities of Bangladesh with the diverse socioeconomic background are yet to think. So finally, poor knowledge and unsatisfactory practice of the parents regarding the management of their febrile children lead to undue concern, which increases the burden on healthcare facilities, and which is really unnecessary sometimes. And I found antibiotic overprescription was also it might be a fault from our side whenever the parents are very much anxious. So we need to have some recommendations like enhancing parental expertise through evidence-based counseling in outdoor patients in every hospital. Whenever we find any attendant with their children with having high concern regarding fever, public awareness campaigns focused on thermometer use and correct antibiotic dosing and frequency, it should be also in our campaign, and education to reduce antibiotic phobia, and we should promote comfort-based care in every institute. So implementation of various educational programs and interventions from the government and media, along with the formulation of an evidence-based national guideline on the management of febrile children in Bangladesh or any other country, especially the underdeveloped countries, to empower parents in disseminating correct information for the care and management of children with febrile illness is crucial from our part. So thank you for me.
Good day, everyone. I'm Serena Sgargi. I collaborate with the Interdisciplinary Institute of Reproductive Medicine in Bologna, Italy, and I thank you for the opportunity of sharing with you this presentation on the potential downsides of generalized abolition of donor anonymity in assisted reproduction, although unfortunately not in person. I have no conflicts of interest to disclose with regard to this presentation. So, at an international level, tissue and cell donation is regulated by common principles, including no remuneration, fair sharing, consent, and anonymity, with the aim of protecting both donors and recipients, as stated, for example, in a resolution of the European Union and in a statement of the WHO that you can see in the slide. Gamete donation is a particular type of tissue and cell donation and has been on the rise, with the number of treatments increasing significantly for both oocytes and sperm, as you can see from the data in the slide, which are pretty impressive. The growing incidence of infertility, the increasing age of prospective parents, and the diffusion of new family forms have driven this increase, which led to the need for more donors, while also raising some ethical concerns, including the ones that we are going to discuss later in the presentation. Gamete donation is generally subject to regulations that can define several subjects, including eligibility criteria for both donors and recipients, screening procedures, donor compensation or reimbursement, the number of offsprings that can be born from a donor, anonymity, which we will discuss later in further detail, gamete storage and transportation, traceability, and data reporting. Regulations for each of these aspects can greatly vary among countries, or even within the same countries, like in the case, for example, of Australia and the US. With reference to donor anonymity, most common formats are totally anonymous, like, for example, in Italy, where donors, recipients, and donor-conceived persons cannot have identifying information about each other. Open donation, like in the UK, which is the opposite system. A partially anonymous or double-track system, where a donor can choose whether they want to be identified later in life or not, such as the case of Denmark. Or known donation, when the donor is known to the recipient. This procedure is allowed in some countries, including, for example, Canada. We might think that gamete donation is a matter regarding just the donor-conceived person, the parents who opted for donation, and the donor. But it is actually a very complex process which involves a large number of stakeholders, including families of each of these subjects, potential half-siblings from other donations, IVF centers which perform the procedure, gamete cryobanks which collect and store gametes. Not only this, on a larger scale, it can involve individual countries with their specific regulations, international organizations like, for example, the European Union, which also issues specific regulations in some cases, social media, which made it easier to get in contact even with people in other countries or people we don't know, and genetic tests provider. This kind of genetic test that is increasingly available also to consumers without the intermediation of a clinic or an IVF center. The presence of so many stakeholders makes the debate on donor anonymity particularly complex. Traditionally, most countries favored anonymous gamete donation models, prioritizing donor privacy and family stability. However, in recent years, this trend has shifted, with an increasing number of countries moving towards non-anonymous donation, sometimes also retroactively, like it happened, for example, in Victoria State in Australia. This occurred following a systematic and powerful lobbying action led by a subgroup of donor-conceived persons opposing anonymity. International and European human rights law have increasingly recognized the concept of knowing one's genetic origin as part of the rights to identity and personal development. However, there's a catch, because if the right to know one's genetic origin is considered a universal human right, it raises the question of whether it should also apply to individuals conceived naturally, and this is particularly relevant given estimates of paternity discrepancy rates around 3.7% in the general population. Extending such a right universally would be extremely difficult and would potentially require controversial measures such as large-scale DNA data banking and widespread or mandatory paternity testing. In this debate, donor-conceived persons are generally regarded as being in the most vulnerable positions, which strengthens arguments in favor of granting them access to information about their genetic origins. And so far, case law is most based on previous cases of adoption, abandonment, or maternity-paternity establishment. But are these cases really comparable to gamete donation, or should a different approach apply for gamete donation? Furthermore, it has to be considered that not all donor-conceived persons want or wish to know the donor identity. So, considering this complexity, the proportionate balancing of competing rights and interests is essential in this context, while being also extremely difficult. And there are potential downsides of generalized abolition of donor anonymity, that should be taken into consideration by lawmakers. And we will see some of them later in the presentation. Unfortunately, data available in literature for the moment are not particularly helpful to try to sort this debate. In fact, there is no strong, consistent quantitative evidence that simply knowing the donor's identity might improve or worsen psychological well-being. While there is evidence that it might matter at a subjective level for identity, curiosity, and personal meaning, which is understandable. Currently available scientific evidence on this subject has significant limitations. There is a limited number of studies available. Samples are often small and selective. Many studies are family type specific, for example, in lesbian couples. There are significant differences depending on geographical and cultural context. And well-being is usually measured with broad clinical scales, which may miss out specific aspects that might be relevant in the debate. So let's have a look at the main downside of donor anonymity abolition. First downside is that knowing identity does not guarantee a healthy child. In fact, in spite of donor screening, disabilities may occur in case of gamete donation as they happen naturally. After initial donor screening, late onset diseases may not be notified, and donors may be unaware of genetic information about themselves. In addition, many genetic disorders involve more than one gene. Epigenetic interaction play a role, and de novo disorders can occur. Finally, being aware of a potential predisposition to hereditary disease does not necessarily imply that it can be currently treated. So access to identifying and genetic information about the donor cannot guarantee a healthy baby, although some recipient may expect it. And this misleading belief may expose clinics, physicians, but also donors to potential risks of wrongfully disabled lawsuits. Secondly, anonymity abolition might lead to a potential shortage of donors. Evidence in literature suggests that in some countries, significant share of potential donors would not be available to donate in a non-anonymous way due to worries about future legal or social obligations toward the offsprings, emotional implications of being identified, or disruption to their own families. This might lead to a potential shortage of donors available, in a reduction of the heterogeneity of the pool of donors available, and subsequently in an increase in the time needed to access treatments. It's interesting to notice that some studies reported that a relevant percentage of anonymous donors appeared to be in favor of the release of non-identifying information about them to donor-conceived persons. The risk of genetic discrimination is another concrete risk. Should specific conditions or predispositions become public, people might be subject to limitations concerning, for example, access to care or employment opportunities, and this is especially true in those settings where healthcare is mostly managed by the private sector. And anonymity abolition, based on the right to know one's genetic origins, reinforces the concept that genetics play a fundamental role in defining one's identity, and that a genetic-based family structure is therefore superior compared to other, based on social or emotional connections. Proper data management is another delicate issue, because management of genetic data and data concerning health status is generally subject to very specific regulations. For example, in the European Union, we have the GDPR. Genetic data and data concerning health status should be collected, processed, and stored exclusively by specifically designed controllers and processors upon authorization of the data subject, and solely on a lawful basis and following specific safety requirements. Abolishing anonymity implies that genetic data and data concerning health, along with identifying information about the donor, can be made available to donor-conceived persons, and potentially to recipient couples, without any guarantees that these data will be processed correctly, and that these data will not be used in an appropriate or illegitimate way, whether it is on purpose or accidentally. Finally, who should be in charge of information provisions with all related responsibilities? This needs to be defined. Should parents be forced to disclosure? Should it be the state? Or should we leave this to physicians? In this last case, another issue arises, as providing donor-conceived persons with information about donors might be in conflict with the concept of medical confidentiality, which is a cornerstone of medical practice. So, in conclusion, generalized abolition of donor anonymity is an oversimplification of an extremely complex issue, with significant personal, familiar, and social implications. Generalized abolition of donor anonymity may have potentially risky implications for individuals involved in the community that policymakers should know and carefully consider. Appropriate measures are needed to balance instances and rights of all stakeholders involved. Donors and recipients at the same time should be aware that despite legal protection of anonymity, this can no longer be fully guaranteed due to the diffusion of direct-to-consumer genetic testing and social media. So, promoting social acceptance of gamete donation along with appropriate counseling at different life stages could contribute to normalize this practice and to gradually reduce the wish for anonymity. With this final message, I thank you very much for your attention.
Hello, my name is Dr. Nnamdi Nduku. I currently work as a specialty doctor in obs and gynae in the United Kingdom. I present enoxaparin-induced abdominal wall haematoma in pregnancy. Abdominal wall haematoma is a rare but it's serious cause of acute abdomen in pregnancy. There is a rising incidence due to increasing use of low molecular weight heparin in pregnancy. It poses a diagnostic challenge as it mimics other causes of acute abdomen pregnancy, such as abruption, uterine rupture, torsion, and acute appendicitis. I present a case of 42-year-old gravid para 5 with 4 previous cesarean sections. I highlight the risk factors in this patient. She was using low molecular weight heparin, has high BMI, advanced maternal age. She had cough at the time of the incident and had multiple surgeries. She presented at 36 weeks with sudden severe abdominal pain following an episode of cough. On presentation, there was tender right-sided abdomen with no vaginal bleeding, normal CTG, normal maternal observations, and bedside ultrasound scan suggested erythroplacental clot. A repeat bedside ultrasound scan was done following worsening symptoms, and it queried torsion of an ovarian cyst. The hemoglobin dropped from 124 gram per liter to 115 gram per liter within 7 hours of presentation. So because of our patients worsening pain and the risk factors, a decision was made for an emergency cesarean section. During the cesarean section, which was done under general anesthesia, gynecological team were in attendance. Intraoperatively, a large retrospective haematoma that measured 20 by 10 centimeters was found, and the surgical team were invited for an input. The surgical team advised conservative management at this point, and the total blood loss at the surgery was about 1900 mils. So the conservative management included close observations, analgesics, antibiotics, oral iron, and regular bloods to monitor for further bleeding. So immediate post-operative period, she was admitted in an intensive unit due to failed intubation. Enoxaparin was withheld for 5 days, and CT abdominal was done on the 5th day, which showed 13 by 7 centimeter reduced hematoma with possible active bleeding. So at this point, interventional radiologists were invited to review and advised to continue conservative management. Patient was discharged home on the 5th post-operative day after having an intravenous iron infusion. So this image shows the CT sagittal view of the CT abdominal that was done on day 5 post-op, and the arrow indicates the hematoma. So in the follow-up period, there was a progressive improvement in clinical states and also progressive reduction in hematoma size as measured with ultrasound scan at each visit, as we can see on the slide. So these are the ultrasound scan images showing the different sizes of the hematoma. So we can see a progressive reduction in the size of the hematoma. So this table shows the blood results from the time of presentation to the 3 months post-operative follow-up. Retrospective hematoma is rare, but we have to consider it in pregnant women, especially those on low molecular weight heparin that present with acute pain. It may occur spontaneously or as a result of iatrogenic factors, as in this case, particularly due to the widespread use of anticoagulation in pregnancy. Patients typically present with severe localized abdominal pain, often in a specific quadrant. This is usually accompanied by signs and symptoms of hypovolemia that correlate with the extent of blood loss. Retrospective hematoma can pose a life-threatening risk to both mother and baby, primarily due to hypovolemia and hypoperfusion. There is need to distinguish it from other causes of acute abdomen in pregnancy, such as the cesarean scar dehiscence, abruption placenta, ovarian torsion, preterm labor, and acute appendicitis. Ultrasound scan or CT imaging are essential for diagnosis. So management depends on how stable the patient is. It could be conservative management if patient is stable. It could be surgical management, or it could be the use of interventional radiology if it is in active bleeding. So what are the key learning points from this presentation? So it's number one is that we have to maintain a high index of suspicion in low molecular weight heparin treated pregnancies. Imaging is required to differentiate from other obstetric emergencies. Multidisciplinary management is crucial and is key to its treatment. Conservative management have been found effective in stable patients. Thank you all for your attention.
Hello everyone, Assalamu alaikum. My name is Dr. Varda Maqsood and I work as a senior house officer at St. Luke's General Hospital in Kilkenny in Ireland in the Department of Obstetrics and Gynecology. And today I will be presenting an audit followed by a re-audit that we conducted with regards to the venous thromboembolism thromboprophylaxis in our department. So the reason we wanted to conduct this audit was because of how important venous thromboembolism is, specifically in pregnancy. It is quite rare and is much more common postnatally, but it can still occur in antenatal patients as well or intrapartum. And it is still one of the main causes of maternal mortality, especially in developed countries like in Ireland. So that's the reason we wanted to evaluate our department. The aims of our audit were to assess how many patients were being scored, both antenatally and postnatally. Was it being documented or not? And even if they were adequately assessed, were they being given the correct dose of thromboprophylaxis? We use Enoxaparin in our department, so that's the reason we use Enoxaparin in our audit as well. So it was a retrospective chart review. We randomly selected 35 charts and just reviewed them using a performa made by us between the months of February and April in 2024. And what we found out was that our compliance was good antenatally. It was as high as 80%. However, the postnatal compliance was very low, only at 28%. Another thing that we found out was that the dosage that was being given to the patients, either it was not correctly calculated according to their risk or according to their weights, or it was not being given for the correct amount of time that we should be giving according to their risk score assessment. So once we had the results, then we had a meeting. We made a team and we created separate antenatal and postnatal risk assessment sheets using the RCOG and RCPI guidelines. We had them approved from our quality improvement department, and then we gave a presentation to the entire department so that they could be incorporated into real practice. Additionally, we also made a sheet to be added to our drug sheet, which had all the weights and the dosages of Enoxaparin written on it. So it was very convenient for the doctor or the nurses to assess and then calculate the doses. And I'll just show you how. So this is the antenatal VTE scoring table where we have all the risk factors according to their scores, and then a small tick box, so it's easy for whoever it is calculating them. And then at the end of it, we have a total score, and then we follow it with the interpretation as well so that there's no confusion. So a score of 2 or less, there's only mobilization. A score of 3, we need to start prophylaxis at 28 weeks. And a score of 4 or more, we need to start prophylaxis from the first trimester. And then obviously we need to have the signature, designation, date, time of the person doing it. Similarly, we had a postnatal VTE scoring form as well. We have all the risk factors according to their scores, followed by tick boxes, again total score, and then the management recommendations, and then the sign, time, date, name of the assessor. So this is the sheet that we had, and we had it added to the entire drug cardex. So multiple pages on the drug sheet. This was an additional page. On the first page of our drug sheet, we always have obviously all of the details of the patients, including their weight and height. So it was very easy for us to use it. We just see the weight of the patient on the first page, and then we come back to this page. We check the weight that the patient falls in, and then followed by the dosage, and Literally, the doctor, they just have to sign and write their MCRN number and the date, and then the patient is going to get the correct dosage. So once we had all of these incorporated into our practice, we decided to conduct a re-audit that was done between August and October in 2025. And again, randomly selected 34 charts. They were reviewed. And what we found out again was that the compliance was good enough antenatally, but postnatally it improved significantly, and we came from 28% to 80%. And additionally, the correct dosing of Enoxaparin, that was really good and improved significantly to 91%. Another small thing that we found out was that postnatally, the patients who were actually not being evaluated, most of them were the private patients. So probably that was one of the reasons why we were lacking behind, and that was again mentioned. So we're still working on a way to come up with a solution for that. So this small quality improvement project, the small audit, it tells us that if we go step by step and we have our targets, we have interventions, we can actually significantly improve any outcome that we want. In this case, specifically improving adherence to the VTE prophylaxis, and obviously which leads to better patient care, improvement in maternity care, and hopefully reduce the rate of and incidence of VTE related maternal mortality. Thank you so much.
First of all, I want to say good morning. I don't know what time is it for you guys in that part of the world, but it's morning here for us. I want to say thank you for having me on this platform. Just to give a little information about my research, I was conducted about 5 years ago, to be exact, right? I never knew I would have been welcome or been privileged to be on a platform such as this. Right? And this is actually my first time doing something of this nature. So please bear with me. I hope I'm speaking clearly so that everyone can understand. Hello? Is anyone there?
Yes, doctor.
Oh, sorry, I didn't hear. Can you hear me clearly? Do you understand the way I speak?
Yes, we understand.
Yes. Coming all the way from Guyana, Guyana is in South America, or the only English-speaking country actually in this part of the world. And I was privileged to do my medical internship at Georgetown Public Hospital Corporation, which is one of the main referred hospitals in Guyana. And during that time, I was able to be supervised by some of my great senior colleagues, whose names are mentioned at the top of the title. So in doing this, we actually came up with this topic because at that time, there was not such being done at the hospital at that time. Mind you, there's still much more work to be done. This is just something that we're able to gather for that time and my stay there at the hospital. So surgical site infection, as we all know, it usually happens at the site where a surgery or a procedure was performed. And sometimes these cases can go undetected just by simple patient not being able to follow up. That's one of the cases, some of the issues that we had at that time of the research. We were unable to have enough data on the follow-up of the patient. And given the time during pandemic, most patients after the cases, they were unable to stay in the hospital for longer periods as normal. So they were sent back home. And given the fact that this is one of the referred hospitals, so this came all the way out of the town into the faraway regions, right? And sometimes we are unable to do most of the follow-up there. So this study was done for the time period during the year 2019 to 2020 December. They had a total number of over 3,000 cases However, at the time of gathering the data, we were unable to retrieve most of the information because we were transitioning from paper filing to computerizing system. So at that time, I was only able to gather information from a total of 703 charts, which only 51 of those met the criteria, right? And can you go up a bit for me? Yeah, thank you. So only 51 of those met the criteria, and we were able to have a prevalence rate of 7.3% of the cases, given the fact that most of these patients, the cases were class 1, the surgical site infection, which in my opinion, is actually good because we were able to detect those earlier than having patients who would develop class 2 and 3 to 4 surgical site infection. So at the time of gathering information, we were trying to group those patients according to the ages, the poverty, those who have comorbidities, and those who probably have a prior C-section before. Yeah. So what we're able to find out is those who were, for the maternal age, those who were between the 20 to 29 years old, they had a higher frequency of deliveries. And what I was able to gather during, going through the charts and so forth, we were able to see those who were the first time pregnancy. And sometimes we have these mothers who don't have, older people around them and not able to do maternal care early in the pregnancy. Sometimes we have those ones who presented within this age group, right? What is significant to know that even though some may present with comorbidities as hypertension and gestational diabetes, it was great to see that those weren't the one that was fully affected by those surgical site infection. Right. I'm trying to go a bit fast. I don't want to take too long. Can you go? But yes. So what we're able to gather to is that majority of the cases that were able to go through during the research, we found that those were the one that presented with the surgical site infection at 98% of those cases, which were actually, as I mentioned, is good because once we have those presenting, we can able to manage effectively and appropriately, right, and in a timely manner. So when we look at the other chart when it comes to the indication for label, thankfully that those who had previous C-section were not affected so much as those who were having a non-reassuring fetal heart rate. So patients who will present in these cases, we always have to do emergency C-section for them. And sometimes when you're doing the emergency surgeries, sometimes some things can be missed, small things can be missed, right? And then we can end up having those develop with surgical site infection. So I think something kindly came out because one of the things that we looked at were the pathogens that are mostly responsible for these infections. And what I was able to gather based on information there, we had the Staphylococcus aureus infection being predominant. So at the hospital, sometimes we will not always able to get samples done, depending if we have cultures, reagents to actually do these tests. Because sometimes we're not able to have all those tests being done on all the patients that are being seen. So the one that we was able to see, we're able to find that, okay, they have the Staphylococcus aureus infection, and those times they are in the preliminary stages. So sometimes it's hard, depends on the workload, to actually have the final results. Sometimes most of these patients are already being discharged with antibiotic therapy and so forth to follow up and so forth. And like I mentioned, at the time, most of these patients came from the outlying regions. So when they went back to their home, the communication got a bit breached in terms of following up them. So one thing I one thing we can actually recommend, come to conclusions that we need adequate aseptic procedures. Even though we may be in an emergency situation, we need to ensure that all these things are being followed, and not to develop surgical site infection, right? And we need to have, if we can have our own our own team that are dedicated to these cases, will be actually good in terms of following these patients. And also, we also noted that because of in our situation, we have to document by hand all the time. So sometimes your hands get weary during documentation, and sometimes you may miss a spelling, you may miss correct diagnosis or so forth. So those are some of the things that they are currently working on, to have those systems being computerized so that we will not miss vital information as those. So thank you so much for listening. This brings me to the end of my short presentation. Thank you.
Good morning, good afternoon, or good evening, depending on where you are. I think it's wonderful. We're getting such a wide range of people in the field of OBGYN to come and support one another and learn from one another. I am actually not an OBGYN. I am a physical medicine rehabilitation trained physician who's primarily practiced sports medicine and non-operative orthopedics. But I came into treating people with pelvic floor dysfunction because they came to me. I had a lot of patients who we were treating for hip disorders, mostly postpartum females who were trying to get back to athletics and were telling me that it wasn't their hip pain anymore that was causing their problems. It was their pelvic floor issues with stress urinary incontinence and fecal incontinence. So started to develop alternative ways to approach these patients. And so a little bit of background on me: I went to Jefferson Medical College in Philadelphia, Pennsylvania. Graduated cum laude. I was trained in physical medicine and rehabilitation at Harvard, and extensive training in musculoskeletal ultrasound, and kind of became an expert in musculoskeletal ultrasound. And that was the big segue on how I was able to develop treatments for pelvic floor disorders and diagnostics as well. So I practiced MSK ultrasound and orthobiologics for the past 12 years, and I teach musculoskeletal ultrasound and orthobiologics at multiple conferences and international courses. Pelvic floor disorders are near and dear to me and my family. My wife is a huge supporter of me conducting this research and these treatments. She herself, who totally approves me talking about this, has experienced pelvic floor disorders from having 6 children, and has experienced symptomatic pelvic floor injury due to the birth of our children, and we experienced secondhand through meeting with traditional OBGYNs and urogyns that there aren't very many options for people suffering from these conditions, and so we were looking for alternatives. So what are the symptoms of pelvic floor dysfunction? Pelvic pain is very common. Urinary incontinence is probably the most common symptom. More severe conditions can have bowel or fecal incontinence, and then another common symptomatology is pelvic organ prolapse, which can lead to exercise activity intolerant sexual dysfunction, and a recent study came out and showed that postpartum depression is highly correlated with symptoms of pelvic floor dysfunction and pelvic organ prolapse postpartum. The prevalence of this is significant. About 30% of all women overall in the world and 10% of men experience pelvic floor dysfunction. 50% of women experience symptoms of pelvic floor dysfunction after a single childbirth. This includes C-section, which decreases the risk for pelvic floor disorders after childbirth. An international study showed that about 75 to 90% of all mothers worldwide will experience symptoms of pelvic floor dysfunction at some point in their life. There is a large treatment gap. There's a lack of gold standard in diagnostics for pelvic floor function and pelvic pain. Difficulty identifying the root cause due to some say it's nerve injury, some say it's quote unquote normal, but we know that it's not normal. There's true injury there that has gone undiagnosed. And there are limited treatment options. Pelvic floor therapy is now available in the United States and in Europe. May or may not be available in some of the other countries where you all reside. Nerve blocks is commonly done by urogynecologists to treat the pain, but it doesn't treat the root cause. Chemodenervation is starting to become more popular, choosing Botox injections, but that's treating the tight muscles that are compensating for the injury and not the actual injury themselves. The surgery also has had some good success for specific conditions. It is successful for prolapse, at least we know in the first 10-year period. Beyond that, we're not sure. However, most studies were done in women who are postmenopausal after the age of 50 to 60, who weren't as active and didn't want to have more children. Surgery is moderately successful, about 70% success rates for levator ani tears, and it's but relatively unsuccessful for fecal incontinence. Sphincterplasties have about close to 100% failure rate at 5 years. The other issue is surgery is not comprehensive, right? You're doing a sacrocolpopexy for prolapse, you're doing a sphincterplasty for fecal incontinence, you're doing a levator ani repair for levator ani tears, and you can combine them, but it's not a comprehensive treatment to the entire pelvic floor, figuring out what everything that's injured and treating everything comprehensively. Pelvic floor disorders are now getting more attention in sports as well. Especially international soccer players. This was an article from the New York Times based on a study about pelvic floor disorders in elite athletes, specifically female soccer players. This was one of the studies that the article talked about, and basically showed that 50% of professional soccer players experience symptoms of pelvic floor dysfunction. These are not postpartum females, right? These are women who are playing active football or soccer professionally, and then these athletes who have played sports their whole life, who then go on to have children, are 9 times more likely to have stress urinary incontinence postpartum. So they're at risk for these pelvic floor disorders to get worse after injury, or if they were not symptomatic before. So we feel like the alternative is to these injuries, an alternative could be biologics. But first, before you would use any biologic to an area, you have to get a proper diagnosis, right? You can't treat an area of injury with a biologic without identifying the injury. So we started using a comprehensive pelvic floor 2-dimensional ultrasound to assess all the muscles of the pelvic floor, both the superficial layer and the deep layer, including the levator ani, the bulbocavernosus, transverse perineum, ischiocavernosus. And we also do a dynamic pelvic organ prolapse exam to see if there's any pelvic organ prolapse with a Valsalva maneuver. We can also see suspensory ligaments and suspensory and the fascia as well, the rectovaginal fascia and the pubocervical fascia. Studies have shown it to be as reliable as 3D ultrasound and MRI for levator ani tears. It is superior from what we found in detecting tears in other muscles other than levator ani, including bulbocavernosus and transverse perineum. It's also we're also able to see, like we talked about, the pubocervical fascia, rectovaginal fascia, and some of the ligaments of the pelvic floor, such as the anococcygeal ligament, pubocervical ligaments as well. The other thing it does is it allows for easy ultrasound guided injection if you identify an injury and you want to treat it with a biologic. So this is just a diagram of the pelvic floor. You've all seen this before. We have, ischiocavernosus, transverse perineum, the levator ani here, and coccygeus. So these are all potential perineal body. These are all potential targets for treatment if they're identified as injured. This is a sagittal view. We also look at the ligaments in the sagittal view. So the main areas we are looking at are the pubocervical fascia and the rectovaginal fascia, but we're also looking at the pubocervical and pubourethral ligaments, coccygeal ligament, and uterosacral ligaments as well. So this is an example of a levator ani tear right here. This is the pubic bone right here, and this is the levator ani tear coming off of here. This is all levator ani muscle right here. This is the bulbocavernosus here, and this is the lateral vaginal wall, and there's a tear here in the lateral vaginal wall here. This is another example of an injury. This is a sagittal view. You have urethra here. You can see there's some dilatation to the urethra. This is a vaginal canal right here. And then this is a perineal tear. So this person had was diagnosed with a stage 3 perineal tear, and they were at birth, and they were sutured here. And you can see there's some scar tissue in here. This is the perineal body here. This is the rectum here. And they were sutured, so it's closed up on the surface, but deep to it, there's a tear extending all the way down through the rectovaginal fascia, all the way perirectally here. And this patient is having symptoms of rectal prolapse because of this. So we published a case, and we're presenting it here, of specifically someone who had a perineal tear and anal sphincter. They had a grade 3B perineal tear that went into the external and a little bit into the internal anal sphincter. And we performed, so the 41-year-old patient who we saw following with fecal incontinence ever since childbirth. She had seen multiple other OBs and urogyns, and they didn't really have many answers to her. The only thing that was offered her was a perineoplasty, but there was no guarantee that was going to improve her symptoms. And so we did a diagnostic ultrasound and saw some injury to the external anal sphincter, as well as a lot of fibrosis around the external anal sphincter. So we performed 2 rounds of platelet-rich plasma directly into the internal anal sphincter, as well as we did do a comprehensive pelvic ultrasound and found injuries in other areas. She completed patient-reported outcomes. We used the PFDI-20, which is a combination of 3 pelvic floor outcomes measures. She had near complete resolution of symptoms and resolution of any fecal incontinence. This was what we treated her with. It was a high volume blood draw to create, and we did a double spin method for platelet-rich plasma. We created about a 10 times concentrated platelet-rich plasma, which is pretty high. Many kits are not able to get that high of a concentration. The ones that we use were able to do that. One issue with these is the injections are somewhat technically difficult. You're not able to see the full length of the needle. If you're familiar with ultrasound guided injections, if any of you, they're done out of plane, so you can only see the tip of your needle, and some are 5 centimeters deep, close to the bowel and bladder. Like if we were going to treat that rectovaginal fascia tear that we saw on that previous ultrasound image, you'd have to go up to 5 centimeters deep. So you need to be, if you're going to do this, you need to be well trained in ultrasound guided injections. These are before and after images. So this was her. This was before the treatment when we ultrasounded the rectal tissue. You could see she had still some tearing that was left over in the external anal sphincter. This is internal anal sphincter here. This tissue is external anal sphincter. And so she still had some tearing there, and she had a lot of fibrosis in her perineum and perineal body. And it was pulling, she had this, a malformation of the rectal tissue due to this injury. And that was causing her to have fecal leaking because her sphincter wasn't able to fully close the lumen of her rectum. And so after 2 treatments, both to the scar tissue and to the injury around it, showed resolution of that malformation, normal looking morphology of the rectal tissue, and her fecal incontinence was completely resolved. This is a depiction of the PFDI-20. It's basically 3 separate measures combined together, one specifically for pelvic ovum prolapse and vaginal symptoms, one for colorectal and anal symptoms, and one for urinary symptoms as well. And so we've been giving this to all our patients who undergo treatment. This was her specific PFDI score. So this was specifically her rectal scores. So her baseline score was 29. So she was, if you go back, so this measure is out of 32. And so it's the CRAD 8 is out of 32, and she was at a 29. So pretty bad symptoms rectally. And she underwent first treatment and then a second treatment after this. This was after first treatment, got down to 14, and then a second treatment, which got her down a little bit more, down to a 12. And her symptoms were sustained. For this, over 8 months, we followed up with her at 2 years, and her symptoms were maintained as improved. So we will update that in the future. So as I talked about, we because of this result, we have treated many more patients with this system. We have 112 patients that have been enrolled, that have been treated. So we have longitudinal data on 52 patients, mostly postpartum, within 2 years of postpartum, majority 30 to 45 years old. And we found with this preliminary data, statistically significant improvement in the PFDI-20, and an approximately 50% drop in the PFDI-20 at 1 year postpartum. Overall, 88% of patients experience statistically significant improvement from their baseline to their outcome data, overall improvement in pelvic function. We've had no long-term adverse effects, no post-treatment infections. There are common side effects or post-treatment. You definitely post-procedure pain. PRP causes a strong inflammatory response, and so that definitely will occur. And patients are, they feel almost post-surgical for the first week. We've had some rare side effects of transient worsening of fecal and urinary incontinence during the recovery phase of the treatment, but never lasting at all. All of that recovers, and almost everyone improves beyond their baseline, even those who got transient worsening of fecal and urinary incontinence after treatment. So this is our preliminary data of total PFDI score. The total is out of, I believe, 150. And so the score on average that we're seeing per patient is about 100. And different patients are getting treatments at different timelines. This is real world data. This is not study data. This is real world data that we are just collecting for right now. And we're showing significant drops in the PFDI-20 scores with treatment to these injuries with platelet-rich plasma. This is specifically, so this is the overall PFDI-20. This is the urinary score drop here. This is the pelvic, so the pelvic organ prolapse scores. And these are the bowel scores overall patients. And this is out 1 year. So overall, if we're looking at data of a singular patient, overall looking at their baseline scores versus afterwards, 76% have had statistically significant improvement of their pain, 77% for specifically the prolapse portion of their symptoms, 82% for their urinary symptoms, 83% for their bowel symptoms, and overall PFDI-20, if you look at baseline versus 1 year out, 88% have had improvement, statistically significant improvement within their symptoms. This is another depiction, but this time this is that same injury to that perineum into the rectovaginal fascia going here. And this is after 2 treatments with platelet-rich plasma. You can see that injury has resolved. And you can see that the rectum is no longer bowing into the vaginal wall here, right? It's bowing here into the vaginal wall, and it's no longer doing that. So in conclusion, the pelvic floor soft tissue injury is often the cause of pelvic pain. And the trauma related to vaginal delivery is often causing soft tissue injury to the pelvic floor. Comprehensive pelvic floor 2D ultrasound can accurately assess pelvic floor injuries in multiple different muscles, tendons, and ligaments. And preliminary data shows that platelet-rich plasma is safe and viable treatment for pelvic floor injuries causing pelvic floor dysfunction. We've had after treating a few people with this, we've had a huge outreach of patients coming from all over the world to our clinic to get treated. And so we are inundated with patients who need these treatments, as we talked about how common these injuries are. And so we're going to start doing training courses as well to teach other physicians on how to do these treatments. And so if anyone is interested in learning how to do them, you can email me at this email, regenerativedoc@gmail.com. Thank you so much for your time.
Good day. I am Dr. Tamara Espinosa Martinez, an obstetrician gynecologist from Mexico. It is an honor to represent my institution at this international symposium to share our experience in the management of acute fatty liver in pregnancy. Liver diseases in pregnancy represent a growing diagnostic challenge in contemporary clinical practice, particularly within the context of the global rise in metabolic disease. Currently, this spectrum encompasses entities ranging from rare but potentially lethal conditions, such as acute fatty liver of pregnancy, to more prevalent disorders like metabolic dysfunction-associated steatotic liver disease, MSLAD. To illustrate these challenges, I will begin with a clinical case. The patient is a 22-year-old female in the 3rd trimester of pregnancy with no prior prenatal care. She presented with abdominal pain and jaundice, which rapidly progressed to hepatic failure and encephalopathy. Due to deteriorating maternal and fetal status, the decision was made to terminate the pregnancy. Subsequently, the patient developed a multi-organ dysfunction requiring management in the intensive care unit. Acute fatty liver of pregnancy was later confirmed, despite initial differential diagnosis including acute cholangitis and preeclampsia with severe features. The patient showed partial improvement within the first 24 hours. However, her clinical status worsened over the following 72 hours. Significant resolution was achieved after the 5th day with a favorable clinical course leading to hospital discharge on day 10, requiring no further medication. Introduction. To begin, we must define acute fatty liver of pregnancy not merely as a pathology but as a true biochemical catastrophe. It is a critical acute hepatocellular dysfunction that, despite advances in maternal fetal medicine, remains associated with high morbidity and mortality for both mother and fetus if immediate intervention is not undertaken. It is characterized by microvesicular fatty infiltration of the hepatocytes. The result of this infiltration is the liver's inability to maintain its normal function. This leads to hepatic failure characterized by hypoglycemia, coagulopathy, severe encephalopathy, and potentially multiple organ failure. Definition. To delve into the subject, we define acute fatty liver of pregnancy not as a simple laboratory alteration, but as a metabolic catastrophe. To explain it simply, it is a liver dysfunction that occurs specifically due to the metabolic stress of gestation, almost always occurring in the 3rd trimester. What I want to emphasize to this forum is the critical nature of this pathology, as it carries an extremely high morbidity and mortality rate. However, the science is clear. If we achieve an early diagnosis and timely termination of pregnancy, the prognosis changes completely. In this disease, time is not just of the essence. It is the life of the mother and the newborn. Etiology. In addressing the etiology, we must acknowledge that we still face unanswered questions. While it has historically been described as having an unknown pathogenesis, today we understand it as a multifactorial phenomenon. Traditionally, an association has been observed with the use of certain drugs such as tetracyclines and valproate, in addition to nutritional deficiency states. Likewise, we cannot ignore the impact of endotoxins derived from infectious processes that can act as triggers. However, for the purpose of clinical updates, it is crucial to highlight that the current paradigm points toward a fetal mitochondrial defect in fatty acid oxidation. This, in turn, overloads the maternal liver and precipitates the cascade of failure that we observe in clinical practice. Epidemiology. Moving on to the epidemiology, we must highlight that although acute fatty liver of pregnancy is a rare complication, with an incidence of 1 case per 7,000 to 13,000 pregnancies, its clinical impact is disproportionate to its rarity. Data indicates that it affects approximately 0.1% of gestations, presenting almost exclusively in the third trimester. As you can observe, we have a critical window of incidence between weeks 35 and 37. One point that usually provides relief to patients, yet requires medical cautions, is recurrence. While it isn't common in subsequent pregnancies, the current standard of care dictates close monitoring from the onset of any future gestation, specifically to rule out underlying genetic risk factors. Risk factors. In order to intervene in a timely manner, we must recognize the high-risk patient profile. Although it can occur in any pregnant woman, there are clear epidemiological markers. First, the classic obstetric profile. It is more frequent in primigravidas and notably in multiple gestations, where the metabolic burden is significantly higher. Second, the genetic and metabolic component. Today we know that fatty acid oxidation disorders, specifically fetal mutations of the LCHAD enzyme, act as critical trigger. When we add pre-existing conditions such as obesity or metabolic disorders, the maternal liver becomes extremely vulnerable. Finally, data from international literature consistently confirms a higher prevalence in gestations involving a male fetus. Identifying these factors collectively is what allows us to maintain a high index of clinical suspicion. During normal pregnancy, to understand how a previously healthy patient can end up in fulminant hepatic failure within a matter of days, we must stop viewing this as an exclusively maternal disease. Acute fatty liver of pregnancy is in reality the result of a fetal-maternal metabolic conflict. The core of the problem lies within the mitochondria, specifically in a process called beta-oxidation of fatty acids. Imagine that the body needs to burn fat for energy, but the fetus has a genetic software error, a deficiency of the enzyme long-chain 3-hydroxyacyl co-dehydrogenase LCHD. What happens then? The fetus cannot process its own fatty acids, and these toxic metabolites return to the maternal circulation. The maternal liver, already under the extreme physiological stress of the third trimester, attempts to compensate for the fetal defect. But a breaking point is reached where the liver becomes overwhelmed and the unprocessed fat begins to accumulate within the liver cells as microvesicles. It is this sequestration of fat inside a hepatocyte that halts liver function and triggers the entire multi-organ failure cascade that we will examine next. Mechanisms of pathogenesis. In this slide, we can graphically see the exact mechanism that triggers the disease. As I previously mentioned, it is a team failure. On the left, we have the fetoplacental unit. The trigger is usually an autosomal recessive hereditary mutation in the fetus affecting the LCHAD enzyme. Essentially, the fetus is unable to complete the beta-oxidation of long-chain fatty acids. Since they cannot be processed, intermediate metabolites accumulate, which are toxic. What happens then? These unoxidized fatty acids cross the placenta and pass directly into the maternal circulation. This is where the crisis occurs. In the third trimester, the mother already has a physiologically diminished capacity to oxidize fats. Her liver is already working at its limit. Upon receiving this massive load of toxic metabolites from the fetus, the maternal liver is simply overwhelmed. It cannot eliminate them, it cannot process them, and as we saw in the previous slide, it ends up storing them out of desperation, leading to microvesicular infiltration. In summary, the fetus produces the toxin, and the mother's liver suffers the functional consequences. To further examine what occurs at the cellular level, let us observe this mitochondrial diagram. This is where theory translates into actual organ damage. As you can see at the top, the normal process of beta-oxidation is interrupted. The red crosses indicate the exact point of failure, LCHAD deficiency, as well as other related enzymes such as MCAD or SCAD. When this step is blocked, long-chain fatty acids cannot be converted into energy, transforming instead into intermediate metabolites and medium-chain fatty acids. Follow the arrow descending toward the maternal circulation. These compounds are not mere passengers, they are highly toxic substances. Once they reach the maternal liver, they trigger a devastating chain reaction, summarized in the 4 critical points on the right. First, the accumulation of these lipotoxic intermediates poisons the hepatocyte. This generates a massive increase in reactive oxygen species, leading to oxidative stress. Inflammatory pathways are activated, which explains the elevation of enzymes observed in the clinical presentation. Finally, the process culminates in apoptosis, or programmed cell death of the hepatic tissue. Hence, the critical importance and urgency of terminating the pregnancy to halt the cycle. This closed cycle, comprising a genetic defect, toxic accumulation, and cell death, explains why acute fatty liver of pregnancy progresses so rapidly toward organ failure. Diagnostic evaluation. Once we understand the pathophysiology, the challenge lies in making a timely diagnosis. As you can see in this clinical pathway, the evaluation is progressive and must be exhaustive. The first step is symptom identification. We must not underestimate nausea, vomiting, or abdominal pain in the 3rd trimester, especially if accompanied by anorexia or any sign of hepatic dysfunction. This compels us to look for multisystem involvement, as acute fatty liver of pregnancy is not limited to the liver. It can present with renal failure, encephalopathy, or even respiratory distress. Regarding the initial study, cognitive evaluation is mandatory to detect early stages of encephalopathy, alongside a comprehensive laboratory profile. Concerning imaging, ultrasound, CT, or MRI, it must be used with caution. A normal study does not rule out the disease, as the infiltration is microvesicular and often invisible to these modalities. Finally, let us discuss liver biopsy. Historically, it has been the gold standard, but today we know it's not essential for urgent management. We reserve it only for cases of reasonable diagnostic uncertainty or for liver transplantation, always preferring the transjugular route to minimize risks. Laboratory findings. To consolidate everything we have discussed, we must master the interpretation of laboratory results. In this comparative table, you can observe how normal parameters shift during pregnancy. But I want us to focus our attention on the column for findings in acute fatty liver of pregnancy. There are 3 markers that serve as true red flags, which you must emphasize in your clinical practice. Hypoglycemia. This is perhaps the most distinctive finding. Unlike preeclampsia or HELLP syndrome, the metabolic failure in acute fatty liver is so profound that the liver loses its gluconeogenesis capacity. If you see a pregnant patient in the 3rd trimester with elevated transaminases and hypoglycemia, it is acute fatty liver until proven otherwise. Hyperuricemia and increased creatinine. Note how ammonia and urate levels rise early on. The increase in uric acid is often disproportionate to the degree of renal failure. It is a marker of poor prognosis reflecting accelerated cellular catabolism. Coagulation profile. Observed through elevated PT, PTT, and decreased fibrinogen. The liver rapidly ceases the production of clotting factors. Seeing low fibrinogen in this context is a warning sign of imminent disseminated intravascular coagulation, DIC. As we can see in the tables, the white blood cell count also tends to rise markedly, exceeding the physiological ranges for the 3rd trimester. Therefore, the key message is, do not wait for jaundice to appear. The combination of moderately elevated transaminases with hypoglycemia and altered coagulation times provides the necessary certainty to intervene immediately. Imaging findings. Let us now discuss diagnostic imaging. As you can observe in this ultrasound, the classic sign is increased echogenicity of the hepatic parenchyma. To identify this, the radiologist uses an internal reference point comparing the brightness of the liver with the renal cortex and medulla. The image demonstrates a hyperechoic liver, suggesting massive fatty infiltration. However, I want to place a clinical emphasis here. Although this image is highly demonstrative, the sensitivity of ultrasound is limited, ranging from 25% to 50%. This is due to the microvesicular nature of the infiltration, which might result in normal reports even on CT or MRI. The message I want you to take home is that a normal ultrasound does not rule out the diagnosis. If the clinical presentation and laboratory results suggest the disease, we must not delay the termination of pregnancy while waiting for imaging confirmation. Histopathological findings. To conclude the technical section, let us observe what we will see under the microscope if a biopsy were performed, although, as previously mentioned, it is rarely necessary for diagnosis. What you see on the screen is a special all-red O stain. These bright red areas are the well-known fat droplets within the vacuolated hepatocytes. Note that they are tiny and multiple. This is what gives the cytoplasm that pathognomonic foamy appearance. In contrast to common macrovesicular steatosis, here the cell nucleus remains centered, surrounded by armies of microvesicles that ultimately stifle mitochondrial function, leading to apoptosis. With this visual evidence of destruction, we can appreciate why we cannot afford to lose any time regarding treatment. Swansea criteria. To standardize the diagnosis and avoid the need for invasive procedures, we utilize the Swansea criteria. As shown in the table, the presence of 6 or more criteria in the absence of another clear cause is required to confirm the diagnosis. I have categorized these criteria to make them easier to recall in clinical practice. Clinical criteria. We monitor more than just nausea and abdominal pain. The presence of encephalopathy or polyuria and polydipsia, indicating transition diabetes insipidus, are high-weight clinical markers. Laboratory criteria. This reinforces what we discussed in previous slides. Hypoglycemia below 72 milligrams per deciliter, elevated transaminases, and the monitoring of ammonia, urate, and creatinine levels help us detect multisystem failure. Imaging and histology criteria. Despite their low sensitivity, if performed, they provide additional evidence for the diagnosis. The most important feature of this tool is its high predictive value. If the patient meets the score, the next step is to initiate the treatment protocol and immediate termination of pregnancy. Differential diagnosis. To conclude the diagnostic phase, it is imperative to conduct a differential analysis. As we see in this diagram, the great challenge lies in the fact that these 3 pathologies share common ground during the 3rd trimester. However, their nuances provide the key to management. First, observe preeclampsia. Here, hypertension is the norm in 100% of cases and is usually severe. Moving toward HELLP syndrome, hypertension is still present in 80% of cases, but the damage is more systemic, manifesting as hemolysis and thrombocytopenia. However, when we reach acute fatty liver of pregnancy, the landscape changes drastically. Note that hypertension is only present in 50% of patients, which can often delay clinical suspicion. What truly defines acute fatty liver are the signs of severe hepatic failure, hypoglycemia, encephalopathy, ascites, and the marked coagulopathy that we do not see with such intensity in the other 2 conditions. Furthermore, acute fatty liver is distinguished by concurrent multi-organ involvement, especially acute kidney injury. We must remember that while it is the least frequent of these conditions, it is the most common cause of acute liver failure of pregnancy. Finally, we must always rule out non-pregnancy related causes such as viral hepatitis or cholelithiasis. Treatment. We have reached the most crucial point. What do we do once the diagnosis is confirmed? The cornerstone of treatment is and remains the prompt termination of pregnancy. There is no medical treatment that can reverse hepatic failure as long as the fetus and the placenta are still present. Management must be simultaneous and aggressive. Maternal stabilization. While preparing for intervention, the goal is to stabilize the mother. This includes the immediate correction of hypoglycemia and the replacement of clotting factors if active hemorrhage is present. Multidisciplinary management. Although it is sometimes difficult to distinguish between acute fatty liver, HELP, or preeclampsia with severe features, the initial treatment remains the same. Therefore, we must act. Critical care logistics. These patients must be managed in an intensive care unit, ICU. Transfer to a tertiary care center with advanced life support and the capacity for liver transplant evaluation is fundamental in case liver function does not recover. It is important to mention that in acute fatty liver of pregnancy, time is hepatic tissue. Components of pregnancy management. Once the decision to terminate the pregnancy has been made, our next step is to quantify the severity of the hepatic failure to anticipate potential complications. As shown in this table, I utilize objective parameters to assign a severity score. We monitor 4 pillars: the presence of ascites, bilirubin and albumin levels, prothrombin time, and the degree of encephalopathy. Why is this vital? Because we applied a model for end-stage liver disease, MELD score. It has been demonstrated that a MELD score of 30 or higher is directly associated with an increased risk of severe maternal complications and serves as a critical indicator for considering survival while awaiting a transplant. This evaluation is not static. It must be continuous. It allows us to identify patients who, despite the termination of pregnancy, continue to deteriorate and require a transplant. Remember, if the points assigned in the table increase during the initial hours, monitoring must be intensified within the ICU. Components of pregnancy management. Once the decision to terminate the pregnancy has been made, management shifts to a critical care support environment. Success in this setting depends on a multidisciplinary team, focusing on 3 pillars of continuous monitoring. Hypoglycemia monitoring. As we have seen, this is the most dangerous metabolic failure. We must perform serum glucose checks every 6 to 8 hours, even if the initial value was normal. Our therapeutic goal is to achieve concentrations above 65 mg per deciliter. Coagulopathy management. This is one of the most sensitive evaluations of true hepatic function. We perform platelet counts, PTT, and fibrinogen levels every 4 to 6 hours. Any worsening in these times is not only a bleeding risk, but a warning sign for an accelerated liver transplant evaluation. Fetal surveillance. While delivery is being finalized, we maintain continuous fetal monitoring to detect any signs of compromise resulting from the maternal metabolic environment. It is fundamental to understand that management does not end at birth. The initial hours of monitoring are what determine whether the liver will begin its recovery process. Postpartum surveillance and prognosis. Following delivery, monitoring continues strictly. The 3 primary causes of maternal morbidity and mortality are hemorrhage, hepatic failure, and acute kidney injury. Fortunately, the prognosis has changed drastically. Maternal mortality has decreased from over 75% to less than 5% today. In most cases, the pathology resolves within 7 to 10 days postpartum as observed in our clinical case. However, we must be prepared for a transient worsening of hepatic and renal functions during the first few hours after delivery. Genetic testing must always be performed on both the neonate and the mother, as it defines the long-term risk of fatty acid oxidation disorders. Follow-up. Finally, the care of these patients extends beyond hospital discharge. We must clearly inform them about the risk of recurrence in future pregnancies due to the genetic basis of this disease. Consequently, for any subsequent gestation, we establish a high surveillance protocol. This includes biweekly visits during the second trimester and mandatory weekly checkups starting from week 34, with the goal of detecting any metabolic deviation before it escalates into a crisis. Conclusions. To conclude this symposium, I would like us to take these fundamental messages back to our clinical practice. First and foremost, clinical suspicion is our most valuable tool. Acute fatty liver of pregnancy is rare, with an incidence of up to 1 in 20,000 deliveries, and its initial symptoms are non-specific. When faced with nausea, vomiting, or abdominal pain in the third trimester, our obligation is to rule out acute fatty liver, HELLP syndrome, and preeclampsia with severe features. Secondly, laboratory results are the interpreters of severity. Finally, it is crucial to remember that the treatment is time. In other words, immediate action. We must remember that in acute fatty liver of pregnancy, diagnostic uncertainty is not resolved by observation but by action. In critical care obstetrics, diagnosis is not a destination. It is a race against time, where every hour gained is an opportunity for life. Thank you very much for your kind attention. I am available at your disposal for any further questions or comments. Please feel free to reach out via email or through Instagram.